It's been a real pleasure working here in Canada, and I especially enjoy working with Adriana because she and I share one similarity, and that is we both like to tell stories. Right? So I have structured my talk today in kind of like a storytelling, or I'm going to tell several stories. And I think I didn't want to make it too heavy, but embedded in each story are going to be a couple of pearls of information that I would like all of us to be able to take home from today. So these were my objectives that I formulated when I was planning for this talk, and we could talk about whether you have any other objectives that are different from what I've put up today. And first of all, I'd like all of us to be aware of all the different ways that HIV can directly and indirectly affect cognition or our thinking processes. Secondly, it is to be aware of how a person's functional ability can be impaired in persons with AIDS who also have cognitive difficulties. And lastly, to be aware of some strategies for people living with HIV and AIDS to maintain or protect their cognitive abilities. So when we talk about the relationship between HIV and cognition, it is really a very complex relationship to begin with. So what I'm going to share with you today is the framework in which I think about the relationship between HIV and cognition. And this is basically the framework that I use in a clinical setting when I'm asked to assess a patient who has been referred for presumed cognitive difficulties. So we know that substance use, abuse, and dependence is also a very common problem in the clients that we see. So indirectly, okay, so even if a person doesn't have HIV, okay, the use of substances, any kind of substances, and I hope to present that to you later, is that the use of substances can affect cognition. And of course, we know that the prevalence of psychiatric disorders like mood disorders, anxiety disorders, psychotic disorders are also higher in the population with HIV, and through that can also affect cognition in the HIV population. The next indirect way, okay, in which they can be related is that of aging, the normal aging process. And we do know for a fact that people with HIV do age faster. So the brain in a person with HIV is an older brain and therefore more vulnerable to the changes that come with age. And we'll talk a little bit about that later. And the next relationship that we're going to talk about is the effects of treatment of HIV, okay, and how that can affect someone's cognitive abilities. And then, of course, the effects of the virus itself. And this is the direct way in which the virus can affect your cognitive abilities. And we're going to be talking about these ways, okay, through opportunistic infections and through HIV-associated neurocognitive disorders. And we're going to spend some time, a little more time on this direct mechanism of HIV on cognition. So this is really the most important slide that you need to take away from this talk, and I think Nicole has had it printed out for you, okay? And it's really to remember this framework, okay, that we're going to talk about today. Okay, so I have a couple of stories, and I'm going to start with the first story. So R is a 53-year-old male who was referred by a housing support agency for a psychiatric assessment. And he has a lifelong history of recurrent incarceration, cocaine addiction, followed by homelessness, and living in stairwells for at least the last 10 years. He reports a history of cocaine-induced psychosis that led him to jump off a building, resulting in broken limbs, broken here, there, everywhere. But he survived. And homelessness is also perpetuated by frequent disconnection from services. However, the caseworker who is currently working with him describes him as someone who remembers information that is told to him and shows up on time every time. Okay? So cognitive difficulties weren't really at the top of our minds at the time of the referral. But during the assessment, okay, he didn't smell very good. He was unshaven. His manner of speaking was very gruff. I don't want to be here, you know. And he tended to be very verbose, very chatty, and often telling very elaborate stories. And But also at the same time, he would very often stray away from the topic that we began with. And so we found it very difficult to redirect him and keep to the focus of the interview. In fact, we had to complete the assessment over 2 or 3 visits. I think it was 3 visits. And when we first talked to him, we thought that he had a very good command of the language, a very good vocabulary. But what happened, to give it away one day, was that I think we were talking about something, and it was in the context of him complaining about how people in authority abuse their power to victimize people who did not have any power or authority. And he actually used the word anthropophagus. And then he went on. And then, so out of curiosity, because I didn't know what the word meant, so I asked him, I said, well, what does that word mean? Can you teach me, what is anthropophagus? And then he said, it means that sort of twisted empathy. And, so he said it meant twisted empathy. So he continued to talk, and then I quietly Googled the word on Google Dictionary, and I found out that the word actually means cannibalism. So it was kind of like totally different. So even if you wanted to have an abstract understanding of the meaning of the word, it didn't come quite close to me, I thought. Okay? So at the end of the assessment, we thought, that most likely it was his chronic use of substances. And we do know, it is in the evidence base that chronic use of any substance, opiates, cocaine, alcohol, inhalants, like glue, result in varying degrees of cognitive impairment. So I wanted to bring this story up because I wanted to highlight, that memory difficulties are not the only sign, and it's also not a consistent sign of cognitive impairment, because I think out there, we talk about forgetfulness, and then forgetfulness is the thing that then, triggers a warning light in our heads, a warning signal that maybe this guy's cognitively impaired, but not always. So memory difficulties are not a consistent sign of cognitive impairment. There might be other domains of cognition and thinking that are affected first before memory. So I think that in this story, that there was a lot of impaired judgment that was resulting in some, bad decision making. And a lot of times if we've known somebody over a course of time, and all of a sudden they start to make some decisions, that we notice that it's really out of character, it doesn't quite make sense, that might actually be a sign of cognitive impairment, that there might be impairment in executive functioning that's resulting in them making those out of character decisions. And I think what was really interesting in this story was that understanding of verbal input, what's being told to you, and also your ability to express that in your language, they are also cognitive abilities, and they are actually also a very common domain that is affected in a variety of neurocognitive disorders. And this manifests as difficulties in communication. So sometimes when we're trying to communicate with somebody and we find that, consistently, so it's not just you, there's also somebody else, another worker, another co-worker who corroborates that the both of you are having difficulty communicating with this client, it may be a sign of cognitive difficulties, So that's some of the pearls that I just wanted to highlight with this story. Okay, so we're going on to the second story now. RH is a 65-year-old single male who has been HIV positive for the last 20 years. He has hypertension, diabetes, and high cholesterol. He also has lipodystrophy from the antiretroviral treatment that he had been on years ago. And about 1 year ago, he suffered a large right-sided stroke that led to an ICU stay because the stroke was hemorrhagic. And he recovered, but he has residual physical disabilities and is still able to live alone and care for himself. However, he was observed to be forgetful, often misplacing his keys, and completely lost them 3 times in the last 1 year. It's been noticed that he requires lots of repetition in order to learn new information. He is also irritable and easily anxious, and that often escalates to verbal agitation. but he has never been explosive or physically aggressive. And when talking to him, very often it was observed that he would often just randomly, spontaneously talk about sexual activity, body parts, excretory functions, and he seems quite blasé about it, and he even finds it amusing. And the very words that were used to describe him was as if he had no inhibitory filter, which I found quite interesting. So on initial interview, he denied any functional difficulties, and he tried to counter those observations with rationalization of his behavior. So we ordered some brain imaging, and MRI of the brain showed a large area of chronic change due to the stroke that he had on the right side, with several small older strokes on the left side. So with this story, I just wanted to highlight the effect of aging as well as the effect of antiretroviral treatment. So we know that as a person ages, chronic metabolic diseases like diabetes, hypertension also become more common. And as we age, the risk of Alzheimer's disease and other neurodegenerative disorders also increases. And in the background, I've also mentioned earlier that we know that a person with HIV ages faster. So as compared to a person without HIV, his body systems are functioning at an older age. So even though he's 65, he's kind of like at the lower end of what we would call a geriatric person. He probably already has the aging processes and the same risk as someone who might be 5 to 10 years older than he is. So because he was diagnosed about 20 years ago, he was probably exposed to the older generation of antiretroviral drugs. And I did tell you just now that he has lipodystrophy from the treatment, and that's a redistribution of fat from the areas of the body. So we do know that the older drugs actually also directly caused metabolic derangements, so derangements in the way that the body handles cholesterol, blood sugar, that also could have had an effect. So what all these chronic metabolic diseases do is that it increases your vascular risk and the risk of the brain suffering from vascular events. And we do know that with more vascular events in the brain, or with each vascular event in the brain, that directly affects your cognitive abilities depending on the area of the brain that it was in. So because he had a really large area of brain damage from the stroke, and we know that when you have such a large area of brain damage, it not only results in cognitive impairment, it also has lots of other effects in your mood, your behavior, and also social behavior, as we could see, like the story that I told you just now. So he had no inhibitory filter. So also to note that when the social inhibition is released, they might actually also engage in more risky behavior. So that is something that we have to take note of in our clients. And also I presented to you in this story that he tried to rationalize his behavior. So we know that with more areas of the brain being damaged, especially in the frontal areas, insight is often lacking, in such clients. So the third story that I have is S, who is a 50-year-old lady who is divorced with no children and currently living in supportive housing. She came to Canada more than 20 years ago, so we don't really know whether she had a background of a psychiatric history in the past before she came. But more than 5 years ago, she was admitted to an inpatient psychiatry unit for worsening low mood, hearing voices, and a drastic reduction of speech and movement. So during that inpatient episode, she was treated with an antidepressant and an antipsychotic medication. And over the last several years, she has had repeated admissions to inpatient psychiatry for similar relapses due to non-adherence to medications. So each of her relapses are marked by confusion, being very, very suspicious toward the staff workers, bizarre behavior such as wandering out in the middle of the night in her nightgown, hearing voices, unsteady gait, and refusal to eat and drink. So after that whole longitudinal course, so the diagnosis was finally settled on a schizoaffective disorder, which is similar to schizophrenia, which some of you might be familiar with. We know that she previously worked as a tailor, but has not worked ever since her psychiatric diagnosis. And in between the episodes of relapse, when she is relatively symptom-free, she is able to self-care, she is able to live fairly independently. However, she has been observed to be gradually more withdrawn over the years, less spontaneous, with less emotional reaction on her face. So psychotic disorders. We know that psychotic disorders affect cognition. Okay, so psychotic disorders such as schizophrenia, schizoaffective disorder, when they're chronic, they usually lead to very marked cognitive impairment. Now, we usually know of psychotic disorders by their positive symptoms, okay? And by positive symptoms, I mean delusions, false beliefs, hallucinations, seeing things or hearing things that are not there. These are our typical positive symptoms of psychosis. But in the chronic phase, we know that there are negative symptoms, okay? And these negative symptoms we know to be apathy, amotivation, lack of facial expression, limited emotional reactions, monotonous and reduced speech, lack of spontaneous movement and activity. So these are all related to cognitive impairment that affect their functional abilities. And as I presented to you in this lady, over the years, so even when she wasn't having the positive symptoms, it was probably the negative symptoms that was causing her to gradually and slowly decline in her function. And one thing to take note of is that we know that some antipsychotic medications do have side effects that may result in a similar presentation. And the more relapses that someone has, the worse the outcome is. We know that, okay, for sure. And unfortunately, the antipsychotic medications that we have available right now, we know that they're not really effective for negative symptoms. They're effective for positive symptoms, but not so much for negative symptoms. So very often in the chronic phase, we find that preserving their function is really a challenge, okay? And which is a challenge that we're having with this particular lady. So the next one. N is a 23-year-old girl who came to join her mother in Canada in time to attend high school here. So she is unsure whether her HIV that was diagnosed in her late teens was contracted by vertical transmission or by a sexual assault when she was much younger, and she is currently in college. So on history taking, she recalls that she missed 1 year of high school because in that year she was barely able to function in school. She described that period where she felt really sad, she could not get out of bed to go to school, she stayed in her room all day with the curtains drawn. She could not even focus on reading a page of her textbook. But she said, unfortunately, she was not assessed or treated for it. So over time, over about a year or so, she slowly got better and eventually she managed to finish high school, but about a year later than her peers. So she went on to college, but unfortunately this same similar episode recurred and she even had to drop out of her course midway. So she found that whenever she was in class, her mind was wandering off, the standard of her assignments deteriorated, she cried frequently, she felt very useless and worthless about herself, and suicidal thoughts also preoccupied her mind. And when you correlate that with the progression of her HIV illness, she does describe that during this time, she was taking her antiretroviral medications very inconsistently. And one of the medications that she was taking was Atripla. And it appears that whenever she had these episodes of difficulties, that coincided with the times when she restarted her antiretroviral medications. So I think the diagnosis here in this story is really quite clear to all of us. We've definitely seen it at some course in our interaction with clients. And something to know is that cognitive difficulty is one of the criterion in the diagnostic criteria that we use for major depression. It's not one of the core criteria, but it is one of the criteria. Okay? And cognitive difficulties in depression can take the form of inability to concentrate or focus. Sometimes patients can tell you that rather than difficulties in concentration, they find that they're very indecisive. So they find that they're vacillating between two options and they can't make up their minds. The other form that it can take is actually preoccupation with depressive ruminations. So sometimes they would actually tell you that they have a specific negative thought and it just keeps going on repeatedly in their minds that they can't stop. And we do know that in the syndrome of depression, there are also vegetative symptoms, and this manifests itself as what we call psychomotor retardation, and this is slowness, general slowness in thinking, moving, execution of something that they've thought of. Okay, so that's also actually also a cognitive difficulty. And when they're generally, when a person is generally physically unwell, the mood is often low too. It's not surprising, right, to know that your mood would be low when you're feeling unwell. So when someone has untreated HIV, okay, and they're physically unwell, okay, their mood is often down too, and that's something to take note of. So of interest is that in this story, this girl was actually taking a triplet which contains efavirenz, okay, and efavirenz is well known to us for being associated with a plethora of neuropsychiatric side effects, and most notably, it is depression, especially in the early phase of treatment. Okay, so this is something to take note of. Okay, so I'm moving on to case 5. Sorry, it's really small, that's why I had it printed out for you guys so it's easier for you to read. Okay, this is one of my favorite stories. MZ is a 46-year-old single male who has post-high school education and used to work as a manager in a restaurant. He stopped working 3 years ago since falling ill with HIV and AIDS and began to live with his mother. His CD4 count at the point of diagnosis was 45 and he had pneumonia at that time. He had significant difficulty tolerating the side effects of different antiretroviral medications and so has not been on a consistent, effective regime as yet at that point. And as a result, during that course of illness, he was diagnosed with left-sided progressive multifocal leukoencephalopathy, PML, resulting in right-sided weakness and numbness. And he even had slurred speech with difficulty swallowing and needed assistance in all his basic activities of daily living. So what was interesting about him was that while he was in the inpatient ward with infectious disease, he was frequently making phone calls. He was asking for home leave, asking for help from volunteers to run errands, and because he still needed some assistance in his ADLs, he was transferred to a rehabilitation facility. So there, he had an episode of agitation that resulted in him cutting his own wrists with that razor blade that he was supposed to use for shaving, and that led him to be transferred to psychiatry. So he continued to be agitated and aggressive when the nurses checked his belongings and wanted to remove his cell phone. So as the story unfolded, it turned out that he had been borrowing money from family, relatives, friends, whoever he could get for a variety of reported reasons until they refused to lend him any more money and they refused to pick up the phone call when it came from him. So he said that this reason was that he was expecting someone from the UK to deposit a large sum of money into his bank account. But before that could happen, he first had to transfer small amounts over first as a processing fee. So he even showed me a picture on his cell phone of a check that had been made out to his name. So then the second reason also was that he said he had to transfer money over to a girl that he had met online, so he's never met her in person. And this girl had told him that she was being abused and she was going to be trafficked overseas. So she had to receive this money from him by a certain deadline, otherwise the trafficker would take her to the airport and traffic her overseas. So he was getting agitated because the deadline was coming up soon and he had to get that money to her. Otherwise, he would never see her again. So again, he showed me on his cell phone a picture of a bosomy girl in sexy poses and said that, she had even promised to marry him and be with him. So at this point, I'll just break the monotony a little bit and ask, what would you do in this situation? Do you have any ideas?
He's clearly being taken advantage of, like he's being scammed by at least one or two different sources. So he's quite vulnerable. So I'm not sure what I'd do about it, but that's a poor man.
Yeah. So do we all agree that he's been scammed not just once but twice consecutively within a short space of time? Yeah. So, and the difficult thing was that he didn't agree that he was being scammed. Yeah, he wasn't aware of it, he didn't know it, and when we tried to explain to him, he didn't agree. Yeah. So that was tough. So what I did was I tried to keep him safe in the ward, and I made a police report on his behalf because he's vulnerable, right? But unfortunately, the police said they couldn't do anything, right? Because they can't bring charges against anyone here. Yeah, so they couldn't do anything. So then the other thing that was always triggering him was the cell phone. Because the cell phone was always that point of contact between him and the scammer. So that cell phone was that trigger for all that agitation. Okay, so the difficulty that we had also was actually removing that trigger or removing that cell phone so that he didn't have that contact anymore. Yeah. So these were some of the challenges. And
So
then,
what happened in the end? I'm pretty sure everyone want to know.
How did you remove the cell phone?
so the thing was, I think I was the one who had the most rapport with him because I had started to see him from the beginning. So every time he was more agitated towards other members of the team, who were seeing him. So I had to go there and just slowly explain to him why we were removing his cell phone, and he seemed to accept it for the first half an hour or so. But after half an hour, then he would forget, and then he would start to yell for his cell phone, right? And it was a difficult family meeting too, so we finally had to get the family involved. And I think what made it a little less difficult was that he had already disclosed his status to his family, so the family knew, so the communication was easier from that point of view. So they also had difficulty understanding that he was not the same person, why he was not the same person that he was before. So all they knew were all these behavioral difficulties that he was causing the family, and they wanted to disown him. They didn't want him to go back to the home. So that was a challenge too. So in the end, I managed to convince the mother that I was gonna take his cell phone and give it to her. So then she had to decide what to do with the cell phone. Yeah. So I had to give her some suggestions. Some options would be maybe to give him a different cell phone with a different number, or something like that. But it was up to her to decide what she wanted to do with it. Yeah. So it took him some time, so it kind of settled after that. And then after that, I don't know because I'm here without telling you more. Yeah. So I don't really know. So that was the acute episode. Okay. So the next story that I'm going to tell you is of P, who is... Oh yes, sorry.
For the last case, obviously he had advanced immunosuppression, he had PML, so a lot of physical changes in his brain. What would you actually call, from a psychiatric point of view, what was it? Is there a specific diagnosis that would fit under? He has very poor insight, he's not making great decisions, just cognitive decline, secondary to HIV.
Yeah, so the neurological diagnosis is PML. So PML is a neurological diagnosis affecting his cognition. So in order to back myself up, I actually also got the psychologist in to do some basic bedside formal testing to document that he had impairments, especially in executive functioning.
So I guess for me, it's also raising the question of when we start to talk about competency. I know it can be and it should be a difficult and lengthy process to take somebody's competency from them, but when somebody is so vulnerable and so clearly impaired, did that conversation come up in this case, or what determines when it becomes
exactly? Yeah. So I guess at this point I have to tell you that that situation took place at a time when in Singapore, when the new Mental Capacity Act had not been effected yet. Okay, so we couldn't have that conversation with the family. So what had been going on was best practice is that the clinician would have to act in the patient's best interest. If we believe and we have the proper documentation that he is cognitively impaired and his capacity is impaired, So that is why I did what I had to do, was to get in a psychologist, do some simple bedside testing, document that there is impairment in the context of a central nervous system neurological involvement due to HIV, so that in case anybody wants to haul me to court, then I have the evidence to back me up saying that he is cognitively impaired, his competency has been impaired, and therefore I was acting in his best interest to protect someone who is vulnerable.
And I think you have a good point. I think here that's what we do, right? We declare incompetent financially from the mental health point of view.
So that was my next question. If we were to transplant this case to a Canadian facility, like that would be.
Yeah, that's what we do.
Yeah.
And probably, I don't know, to do any any treatment, like anything to kind of like pharmacological treatment.
So we did have him on some antipsychotics, but that was more for like tranquilization to calm him down. But basically the treatment is really treatment for PML. But as it is, we know treatment for PML, we don't know how long it takes for it to work, and eventually whether things can recover from the central nervous system perspective. So you have to anticipate and have in your mind that that he is going to continue to be cognitively impaired. Yeah.
Is PML only associated with HIV?
It is an opportunistic infection, okay, and we do know that it comes about when someone's immune system is severely suppressed. And most commonly in this day and age, it is in a situation of advanced HIV. Yeah. Okay. So P is a 55-year-old male, single, and living with his brother in supportive housing. He was diagnosed with HIV about 4 years ago and presented at that time with another opportunistic infection of the brain, CMV, and the CD4 was less than 100. So treatment was initiated and he had improved medically, but it was noted that his behavior started to deteriorate. He became very forgetful, repetitive, was episodically agitated, aggressive, yelling at his brother when he didn't get his own way. He would wander out of the house, pick up cigarette stubs from the street, or ask strangers for a smoke, and once even attempting to snatch a cigarette from someone that he had never met. He was also urinating and defecating indiscriminately instead of inside washrooms. He was inappropriate and disinhibited towards staff and doctors, hugging them, kissing them, asking them personal questions about their families and their sex lives, and also often used crude terms. Eating patterns were also bizarre. He would go from having a period of time where he would eat the same thing for every meal every day, or he would have a period where he would take one huge meal in a day. So, and he also did not sleep well and would disturb his brother every time he woke up in the middle of the night. And MRI of the brain showed generalized just wasting. It was smaller than someone, a normal control that is same age. So we couldn't send him for neuropsychological testing because of his behavior, okay, but I think it's pretty obvious here. Okay. So now we'll finally come to the part in which HIV can directly affect cognition, okay? So we've talked about opportunistic infections in the central nervous system, okay, because when you have a lesion growing in your brain, it's bound to have pressure effects, sometimes swelling, okay, sometimes neurons die, and all these things, okay, directly affect the brain functions. And the most important function of the brain is to think, right? So we're also going to talk about HIV-associated neurocognitive disorders, okay? And there are 3 ways in which you can have a neurocognitive disorder from HIV. So research has actually shown us that very early on in the phase of infection, so once the virus enters the body, they actually enter the central nervous system very early, okay? And they form a reservoir there, okay? Because there, it is very difficult for the general immune system to enter the CNS and attack the virus there. So it forms a protected kind of reservoir inside. There have also been instances where we've seen patients with very stable, treated HIV on medication, doing very well, okay? But there have been case reports where there was viral escape into the central nervous system. So how they knew was that if they did a lumbar tap and retrieved some of the cerebral spinal fluid and measured the viral load in the CSF, they would measure detectable levels of the virus in the CSF. So the other way in which we can see hand is through IRIS, immune reconstitution inflammatory syndrome. So this is what happens when someone who has had very, very advanced HIV disease just started on antiretroviral medications, and then the body's immune system starts to wake up and it causes the inflammatory reaction of the body to go into overdrive. Okay? And it is that overdrive that then causes lots of other effects on the body as well. And there, early on in the days when IRIS was being recognized, there were a couple of case reports of people with rapidly progressive cognitive decline when they were having IRIS. Okay, so this is the table that I cannot claim credit for because this is on Adriana's desktop in the office. Okay, so these are all the risk factors, okay, divided into sub-headings for us to remember of what are the things that would increase a person's risk of having an HIV-associated neurocognitive disorder. So the important ones to remember are first, if they've ever had a very low nadir CD4 count. So the very lowest it has ever gone in the course of their illness. And we know that if that CD4 count was ever less than 200, it was really low, okay, the risk of having hand increases. So how about right now, at the point when you see them? Also, when you see them right now, if their current CD4 count is very low, that also would have to set off some warning lights in our heads. And also if they've got very high viral loads in their blood or in their cerebral spinal fluid. So if they've had HIV for a very long time, okay, that would also raise some warning signals. And if it's also one of the cases that we talked about, if they've had a history of HIV-related infections or diseases in the central nervous system. Okay, so these are the important disease-related risk factors, okay, that we need to remember. But also we know that if they've not been very consistent with their antiretroviral medications, or if for some reason or other their course of treatment was marked by interruptions, or for some reason or other they were on a regime that is not really optimal in stabilizing the disease, especially regimens that do not enter the CNS well enough, effectively enough, and also certain medications like what I mentioned before, efavirenz, that is potentially neurotoxic, or in patients who have failed treatment or have developed viral resistance. And usually viral resistance develops from some or other or combination of what's going on. They've not been consistent with their medications, the treatment course has been interrupted many times. So that breeds viral resistance. Okay. Now some of the other things that we talk about in patients are if there's comorbid hepatitis C, that also increases the risk. We've also talked about vascular events. So if you have risk factors, okay, cardiovascular risk factors, you've had diabetes, hypertension, high cholesterol, you've had a history of stroke or a history of a heart attack, okay, all those increase the vulnerability of the brain. And also if you've had a comorbid or existing current psychiatric disorder, okay, that also increases your risk. And if you've had a brain injury before, depending on the extent of the brain injury, and also in the past or ongoing substance use. Okay? And then the type of patient that we're looking at, if they're slightly older, okay? Now, you might ask me, what do I mean by slightly older? Is there like a cutoff age or something like that, right? Okay. I don't know about here, but in a study that I did back in Singapore, I found that if they were older than 45, okay, in an Asian population, if they were older than 45, in an HIV positive population, that's what you would consider an older person, okay? So if they've had lower levels of education, if they were of a lower socioeconomic status, they've also had a progress in their life where, they've not had access to care very often, and if they're really, really very poor, we know that all these things because are then related to all or some of these other factors, right? So if they've not have access to care, if they were really very poor, then you know that substance use is probably going to be an issue. Poor adherence to medications is probably going to be an issue. Comorbidities is probably also going to be an issue. Okay, so all these are related. Okay, so I'm going to take a commercial break a little bit, okay, and I'm going to tell you another story, okay, which is not printed out for you. So this is where I live, where I used to live, and I'm going back to live, okay, in this place called Singapore, okay. And this story takes place many, many white hairs ago, when I was in early training, and at that time I was training in internal medicine, and I was doing my first ever rotation in infectious diseases. And back at that time, infectious diseases patients were housed at a place that was off-site from the main hospital, in this place called the Communicable Disease Center, the CDC. Okay? And Singapore, if you didn't know, used to be a British colony, like Canada. And so we had this compound that had lots of colonial style, low-rise buildings. It was kind of nice, it would give you a country feeling. And so it was here where I had my first contact with patients with HIV and AIDS. So one day, on a quiet afternoon, I received a new admission who had come with his father. This is not the real picture, okay? This is just a picture that represents him. It's a picture that I got off Google Images. But he came in like that. The patient came in like that. He was all skin and bones. He was all of 40 years old. He was not talking. He was not breathing very well. He had not been eating, obviously. So the father was a very old school, traditional Chinese father who was obviously very clueless about what was happening. So when we looked into the old records and all that, we found out that he had actually been diagnosed with HIV several years ago, but had never come back for follow-up or started on any kind of treatment. So the history, according to his father, was that since a couple of months ago, he started to decline. He was working well, but then he started to decline. And how it declined was that he started to just become quieter, spending more time in his room, and just coming out for meals and washroom. And eventually that also declined. So eventually he didn't even come out of the room at all. He didn't eat. Until the clueless father suddenly had a realization that something was wrong and he needed to get into the hospital. So obviously he didn't know anything that was going on, because obviously the patient had not disclosed his status to anyone in the family. So he brought him in, came here, and he was like that. And that started me on this path of learning about HIV. And I will give you a cliffhanger here. I won't tell you the ending of the story yet. I'll leave that till much later. And we'll go on. So more about HIV and direct cognitive effects. So there are 3 subcategories of HAND. We have the asymptomatic, the mild disorder, and of course the HIV dementia. Okay, so how clinicians decide which category they're in is based on the level of impairment, and that's based on objective, formal neuropsychological testing, as well as the level of functional impairment. And early on in the presentation, when I showed you all the other indirect effects that HIV can have on cognition, we need to exclude all other causes of cognitive impairment. So this is the way to think about it. So the biggest circle, okay, is the asymptomatic form. And by definition, they would, on formal neuropsychological testing, they would have to demonstrate abnormality in at least 2 cognitive domains. The next smaller circle is the mild disorder, where you had demonstrated cognitive impairment, but very mild functional impairment. And the smallest circle is that of HIV-associated dementia, where you would have marked cognitive impairment with marked functional impairment. And usually in those situations, it's not easy to miss, right? It's usually fairly obvious. So again, global studies have shown us that about 30% of people with HIV have the asymptomatic type. Okay? So those are the ones that it will be really easy to miss, okay, unless you got hold of somebody and made them sit down and do some testing, right? And then about 20 to 30% have the mild form, and about 2 to 8% have dementia, okay? So this is in stark contrast to the days before we had current available treatments. So in the old days, a lot of times we often saw AIDS dementia, okay, and what that was then known as the AIDS dementia complex, okay, which is what the guy had in the story that I just told you, who just came in lying down, skin and bones, not eating, not drinking, not talking. But now with all the available treatments, the circles have all changed. So only a minority, we're not seeing dementia so much, but we're seeing the milder forms of cognitive impairment. Okay. So as I said before, some dementia is usually fairly obvious, but sometimes in situations where the clinical diagnosis is challenging, and that's where formal neuropsychological testing will help. And also, like other types of dementia, we may be familiar with people with Alzheimer's dementia, vascular dementia, and it's kind of the same. They're also associated with behavioral challenges that require a combination of medication and non-medication strategies to manage. Okay, so just like the patient that I told you about with PML, okay, medications actually play only a very small role in acute tranquilization, but the main approach to management for him was actually more behavioral and non-pharmacological. So this is the last story, or actually this is 1.5 stories. Okay, so this is the last story that I have, and I still owe you an ending to the story, right? Okay. So we're gonna go through this case, and then we could have a little short discussion on what some of your thoughts are, okay, based on what we've heard so far. So E is a 47-year-old male born in Canada to immigrant parents. He is a university graduate with his own busy allied health practice, and he was referred for assessment because of functional difficulties in the last 6 months. He has been struggling to keep on top of things in his practice, and his staff have noticed mistakes and forgetfulness. He lives alone, and his sister, who visits him regularly, reports that he has not maintained his apartment like he used to. He mainly complains of loss of interest, energy, and motivation, with difficulties in concentration and organization, as well as sleep difficulties. He does not have thoughts of worthlessness or suicide. HIV was diagnosed about 5 years ago, and CD4 was about 150 at that point. He did not have any comorbid sexually transmitted infections or opportunistic infections. His current CD4 is more than 400 and viral load is undetectable, and he has been adherent to all his medications. So prior to the onset of these difficulties, he has a history of about a few years of daily drinking of alcohol till he is intoxicated, as well as regular weekend use of cocaine and crystal meth. A couple of months ago, his family doctor gave him a trial of an antidepressant, but he felt that it had no effect on him whatsoever. So let's use this time for some interaction, and maybe let me hear what some of your thoughts could be.
What areas was he on?
I think he's on newer ones. I think he was on Truvada and Raltegravir, I think, if I remember correctly. But I don't know the specifics off the top of my head. No, you don't.
How long was the trial of antidepressant?
About 2 or 3 months. Yeah, because by the time he came to see me, he was already he already had a history of 6 months of difficulties.
Not even a partial response?
No, he felt no difference.
How long before this did he stop drinking and using substances?
He was still drinking, and he was still using on weekends. Yeah. So I think you brought up some interesting points, right? That there's a role of substances here for him, right? So that's something that we cannot brush aside. And then you mentioned whether it was potentially the effects of the medications, whether it was being neurotoxic for him. Okay. And then there was also a question of whether this is depression. Did he have a good trial of antidepressants, right? Yeah, so those are all the relevant questions that we're thinking about for him. Because if you count the symptoms of depression, energy, motivation, difficulty, concentration, sleep, no thoughts of worthiness or suicide, doesn't quite meet the 4 criteria for a major depressive disorder. Yeah? But that's something to think about. Anything else?
Thyroid?
Sorry?
This is thyroid check.
Was his thyroid checked? Yes, his thyroid was checked and it's normal. Thank you.
This is familiar history of psychiatric illness
No, he doesn't. So this is his first episode, first ever referral to a psychiatrist.
and within his family.
No family history. But there is a family history of alcoholism. Yeah. So the point is, okay, and I highlighted this story is because I just wanted to reinforce all the points that we talked about earlier, that we have to consider all those things in the framework that we have when we have a client like that. We have to remember all those different ways in which indirect and direct in which HIV can affect cognition. So at this point, I still don't know what the diagnosis is, okay, but he's still under follow. Okay? Anyone else has any last thoughts? No? Okay. So again, I brought up this picture because it is the most important slide that we should remember, okay, and it's all these different mechanisms, okay, of the relationship between HIV and cognition. So all the stories that I've told you about, okay, and hopefully you now have an understanding of how cognition can affect your function. So very early on, especially as a younger person, we will notice difficulties at the workplace, difficulties in employment, coping with employment, sustaining employment, okay? But that also depends on how challenging the work is and how the individual has been coping in the past and how the individual is coping now with the challenges in the job. The other common aspect in which we can see functional ability is actually impaired driving. Because there's also safety issues to consider here. So driving is something that we all need to consider. Driving is a very complex activity. And when we're on that topic of complex activity, to me, because I don't drive very much, cooking is another complex activity that I like to ask about personally. When I interview a patient, I ask about cooking. Yeah, okay. And also, like I mentioned before, when all of a sudden we see someone who is making out of character major life decisions, okay, because that could be a sign of how their decision-making capacity is being impaired. And also, like in the case of PML that we saw, difficulties in financial management. Okay, difficulty in making decisions regarding how to use their money, spend their money, invest their money even. Okay, and also for our patients, okay, our patients with HIV, many of them have very complex medication regimes, okay, and that's also a complex activity that requires multiple cognitive domains, okay. Okay, so I'm going to talk a little bit of how we do things in the office to screen for hand, okay. I know it's not very clear, but I don't know whether you've seen this before. This is the International HIV Memory Scale, the IHDS, okay. So there are 3 tests, okay. Motor speed, where we get them to tap the first and second finger of the non-dominant hand, okay, as fast as they can and time it. It tests for psychomotor speed, so basically we ask them to do this complex activity repeatedly, like that, okay. And as well as memory recall, we ask them to remember 4 items, okay, and there's an opportunity for half-point scoring because if you can give them a cue, a category cue, and they remember it, they still get a half point, okay? And it's scored out of 12, so the maximum score is 444 out of 12, and the cutoff is 10. So if anybody scores less than 10, that is considered to be sensitive, and you should consider this person or suspect this person to have HIV dementia, okay? But it's not very sensitive for the milder forms of hand. Okay, yeah, so I told you this. Okay, so I think we're more familiar with this, okay, the MoCA. We're also familiar with the MMSE, okay. But currently the studies have not shown MoCA or MMSE to be effective for screening of hand. However, in other places, if they're very limited in resources, okay, they might still be useful. there's some evidence suggesting that when you use the MOCA or the IHDS in combination with other shorter tests, that may actually improve the sensitivity of screening. So this is where I owe you the ending of my story, right? Of that guy, that 40-year-old guy. So unfortunately, before the end of 2 weeks in the inpatient ward, he died. Yeah. And back then, it was very sad. So it was, I think it was a regulation or something for caretakers that they would have to manage the body and have them cremated within 24 hours. I don't know whether that's still the same today, but I gotta go check. So it was very difficult also because of the non-disclosure status of the family. But I think without saying anything, they kind of already knew.
Just a question, after the person dies, can you disclose the status of the individuals?
I suppose we could, but in this case, I think we can.
Why you would disclose?
If the family asked or had concerns or questions of the death.
But I think we want to carry
Because
on the
it
patient's
seems like
wishes.
the father or the family member did not know, so it would have provided more comfort in the long run.
But I think we wanted to carry on the patient's wishes when he was
I don't
alive.
think we can. It's a good question, but I think legally we can't. Just
What if we were requesting an autopsy?
Yeah.
Good question.
I mean, if the family was requesting an autopsy for somebody who died, so, yeah.
I guess we couldn't reject that either.
I don't know the answer.
Yeah.
It's a good question.
Yeah, it's a good question. So something that we need to find out. But fortunately for us, in this case, they asked us directly. They knew. So without us saying anything, they already kind of knew the answer. So we didn't really have to directly acknowledge or anything. I think in unspoken ways, we kind of knew. Yeah.
Probably if it would be another, I know it was a short period of time between the patient being in the hospital, but probably would be during the time we had with the patient, somehow support the patient to tell the family, for him to feel, he was dying, having this resolve in his life, for the family as well, right? So probably if I was involved with that patient, that's what I would do, as much I could to support the patient, to disclose to the family at that moment. Like when we always say to support the patient to leave things as most resolved, so probably would be part of the goals during those 2 weeks,
Yeah. Yeah, but it was really tough because, so like I said, he was just not talking at all. He was more or less quite vegetative already. It was really advanced. Yeah, so that was just one of the tough issues in the past. So I think what we're interested in now, is really to think about what we can do to protect what we already have and not lose more of what we're losing every day, right? Okay. So again, it's to recall this picture, and address everything that is here. Okay, so because we already said that HIV affects cognition directly via opportunistic infections and via all these early reactions in the illness, so early testing, early initiation of treatment, is very, very important. Okay, so those are the important things that's very intuitive to us. But now that we know more of how HIV affects the brain, this becomes even more important. And you might take the next thing as generic advice for everything, but I'll tell you why it's not so generic. That people should be actively involved in managing their own health. So, adherence to medications. I think we all know, based on our experience with clients like that, how non-adherence to medications actually has such a great impact on the course of their illness. It just exposes them to so many other complications. It increases their vulnerability, the vulnerability of their brain in particular, to all these other complications that would affect the way that they can take care of themselves and the way that they function in daily life. So managing chronic metabolic diseases, okay, has the effect of reducing a person's vascular risk, okay, which is more important for a person with HIV who is already at increased vulnerability, okay. So managing the blood pressure, managing the blood sugar, managing the cholesterol, okay, becomes very, very important in the management, outpatient management of HIV. So again, good nutrition and exercise sounds very generic, okay? And I think one day I hope, pretty soon actually, I hope to do a study on how body mass index is related to their cognitive functioning, okay? Because we do know that overweight, obese people, okay, have poorer cognitive performance on neuropsychological testing, but also the very underweight, the very cachectic, okay? So we want to know the impact of nutrition and exercise on cognitive functioning. So, sleep, okay? Now, sleep is an underestimated factor in cognitive functioning, okay? So current studies in Alzheimer's dementia, okay, there have been studies showing, following up a cohort of elderly people, showing that people who have more fragmented sleep patterns are actually at higher risk of being diagnosed with Alzheimer's disease later in life, okay? So sleep is a very important factor to protect our cognition, very underestimated, sounds very generic, but to me, sleep is a very important thing to maintain, okay? Cute, right? But not my kid, unfortunately. Yeah. So the other thing also is in their general lifestyles, if they can manage their stress well, okay? So you might feel heavy laden, but if you can manage your stress well enough that you can feel so free, like you're jumping in the air, okay, that also helps to develop emotional resilience, protects you against psychological distress, psychiatric disorders like depression, okay. These will also help to protect your brain, okay. Continuing to be socially connected within the community, okay. Continuing to have meaningful, engaging relationships with people, okay, also increases your feeling of self-esteem, self-worth, helps to develop emotional resilience, okay, also helps to protect your brain. Maintaining access to healthcare, and that's why we're all here, because we want to help our clients or the people that we know maintain that relationship with the healthcare provider, okay, so that they can continue in treatment, okay. So even if it looks really difficult, okay, so somehow they just gotta squeeze into the line, okay, and maintain that access. Addressing substance issues, very often this is the more ongoing pressing issue, okay, and that we should highlight them and have it addressed as soon as we can. Also, effective treatment of psychiatric disorders until recovery and remission, and that may take some time. So sometimes in the clinical setting, when we've assessed somebody and we feel that the psychiatric disorder like depression or anxiety or psychosis is the main issue right now, we would actually say we would treat this first and then defer the cognitive testing till their symptoms are much better, okay? So really taking the big picture view, okay, the journey is tough, but when you reach there, the view is great, okay? So the journey is tough in order to prevent complications of the disease. And also sometimes, if we already see problems, we need to be ready for important changes, okay, in life. And that may mean a change in antiretroviral medications, and that itself may come with it some difficulties and challenges, okay? But really, it's keeping the big picture in mind. It is really to protect overall well-being, protect brain functioning, okay? And also very important is to educate caregivers, okay? Educate caregivers about what's going on. I don't know whether you've seen this going on around Facebook, but I did, and I shared this link. Okay, so if only physical diseases were treated like mental illness, what would somebody say? So if you had somebody lying down with a tummy ache I get that you have food poisoning and all, but you have to at least make an effort. Or somebody's puking all over the washroom. Have you tried, like, not having the flu? Somebody's bleeding away from a cut. It's like you're not even trying. Right? Yeah, and then somebody's injecting insulin for diabetes. I don't think it's healthy that you have to take medication every day just to feel normal. Don't you worry that it's changing you from who you really are? I mean, imagine that, right? If somebody said that to somebody who needs to inject insulin every day. Yeah, so it's really about educating caregivers, okay? Sometimes when there really is a cognitive issue that's going on, and that's driving whatever behavior that it manifests in, so that, because a lot of times there's a lot of anger, there's a lot of resentment, and they're like, why can't you just, do things this way? And sometimes it's because they're not aware, okay, that there are real issues and challenges in their cognitive functioning. Okay. So, as I mentioned, I remember this story, okay, because this is that's what started me on this journey of learning more about HIV and specifically in pursuing HIV psychiatry. Because I think you and I, we both believe that we should never see patients like that again. We shouldn't, okay? And we should work towards that, okay? And I think what I just want to end off with is by saying that I think mental disorders, mental difficulties, including psychiatric disorders, cognitive disorders, they are different from physical illnesses because most of all, they affect our capacity to have meaningful relationships in the world with other people, okay? And I think that is the main purpose, and that is what drives us to do this work, is because we want to restore this capacity where it has been impaired. Restore this capacity for people to have meaningful connections with the people around them. Okay? So with that, thank you very much for